Are you recording? Okay. Thank you very much. Okay. Welcome to the fourth session of Rheumatology Case Presentation Conference. My name is Elahe Baharvan. I'm Assistant Professor of Internal Medicine at Shariati Hospital, Tehran University of Medical Sciences. And today we are hosting you, me and my dear friend, Dr. Faiz Bijani, who is also an Assistant Professor of Internal Medicine here at Shariati Hospital, who is also Head Manager of Educational Development Office of Shariati Hospital. So this session, we are going to talk about a 32-year-old woman with systemic lupus erythematosus and abdominal pain. As we all know, the head of the course and our great speaker is Dr. Taher Faizi, Professor of Rheumatology, Head of Rheumatology Division in Shariati Hospital, Head of Connective Tissue Disease Unit in Rheumatology Research Center at Tehran University of Medical Sciences. We are very grateful to Dr. Arzu Khosrowshahi, who has been with us during these previous sessions as well as today. She is an Associate Professor of Medicine, Rheumatology Division, and also the Director of Clinical Trials at
I lost share screen. I can't see the screen.
Dr. Baharvan, we have no your sound.
I think we lost Dr. Baharvan.
Yeah. Dr. Baharvan.
Sorry for the inconvenience. We will back in a few minutes.
Okay, I'm really sorry. I was kicked out of the room and I cannot rejoin with my laptop. So I'm here, and I was kindly going to say that Dr. Khosrowshahi, Associate Professor of Medicine at Rheumatology Division of Emory University, has kindly been with us during the previous sessions. Also, we have here with us, we are very honored to have Dr. Nikrat Shahnawaz, Associate Professor of Medicine, Division of Digestive Diseases at Emory University School of Medicine, United States of America. Our next speaker is Dr. Amir Reza Radmard, who is an Associate Professor of Radiology here at Shariati Hospital, Tehran University of Medical Sciences. We also might have Dr. Farid Kosari with us, Professor of Pathology at Department of Pathology, Shariati Hospital, Tehran University of Medical Sciences. And it is really great today that we have a case presenter, our rheumatology fellow in training, Dr. Somaye Surureddin, with us. And we are really grateful for her contribution to the case today. So I hope that you would enjoy this session. And Dr. Surureddin, the scene is all yours. Thank you.
Thank you, Dr. Baharvan. Hello, everyone. I'm so glad to be here. And also want to appreciate Professor Faizi for giving me the chance to be in this CPC. Shall I go on? The case is about 42-year-old woman with abdominal pain. A 42-year-old woman was admitted to hospital because of abdominal pain. She had a history of lupus since 15 years before admission. The patient reported postprandial preumbilical pain about 5 days before admission. The pain had no radiation, no relation to position, no nausea and vomiting, no bleeding, no diarrhea. She reported 10 kilogram weight loss during 1 month before admission. She did not have fevers, weakness, oral ulcers, skin rash, hair loss, arthralgia, thoracic chest pain, dyspnea, or headache. Oh, what happened? I'm sorry. She had epigastric pain 1 month before admission with nausea and vomiting. On her ultrasonography, it said mild thickening of gallbladder, grade 2 fatty liver. Other findings were normal. Her upper endoscopy findings showed erosive gastritis. She underwent laparoscopic cholecystectomy. She had improvement on her epigastric pain after cholecystectomy. A diagnosis of systemic lupus erythematosus had been made 15 years before admission with malar rush, oral ulcer, arthritis, digital gangrene, digital vasculitis, leukopenia, positive FANA, positive anti-double-stranded DNA, low C3 and low C4, negative APL antibodies. IV cyclophosphamide and pulsar methylprednisolone were administered at disease onset because of digital vasculitis. That cyclophosphamide was continued 12 periods. 2 months before admission, she had history of PTSD after a car accident. Her blood results 2 months before admission showed WBC 6,500, hemoglobin was 12, platelet count 450,000, ESR was 90, urine analysis was normal, CRP 14, anti-double-stranded DNA was 500, C345, C46. With diagnosis of PTSD, citalopram, amitriptyline, and chlordiazepoxide were prescribed for her. And despite serologic activity of lupus, no drug changes was done. Her drug history on admission was prednisolone 5 mg per day, hydroxychloroquine 200 mg per day, azathioprine 50 mg per day. She had no herbal supplements, no allergy. She was single. She did not smoke, drink alcohol, or use illicit drugs. On her physical examination, she looks ill, but she was not toxic. Temperature was 37 degrees, blood pressure 130/80, pulse rate was 80 beats per minute, respiratory rate 18 breaths per minute. Abdomen was soft with tenderness in deep palpation. Neither guarding nor rebound tenderness was detected. Bubble sounds were decreased. The remainder of the examination were normal. Primary test results. Here in this table, you can see patient CBC and active phase reactant from different times before admission. As I mentioned before, 2 months before admission, her ESR was 90, CRP was 14. 1 month before admission, when she underwent cholecystectomy, WBC was 70,800, hemoglobin was 11, platelet count 380,000, and CRP was over 150. In the day of admission, WBC was 8,700, hemoglobin 11, platelet count 670,000, ESR was 110, CRP 90. SGOT 35, SGBT 21, alkaline phosphatase 149, amylase 50, lipase 29, and other remainder of lab data were normal. Urine analysis was normal. Troponin was negative. PT and PTT and INR all were in normal range. Iron binding capacity, ferritin, total creatine, albumin all were in normal range. Viral markers were negative. On EKG, she had non-specific ST segment and T-wave abnormalities. Her electrocardiographic showed that ejection fraction is 45 to 50%, and she had apical hypokinesia. And about patient problem list.
Thank you, Dr. Suruddin. Now we have a patient with a history of the lupus since 15 years before admission, with history of the digital vasculitis at the disease onset, and the history of the cyclophosphamide receiving at that time, and history of the PTSD 2 months before admission, history of the cholecystectomy 1 month before admission, and some manifestation of active serology 2 months ago with the high anti-double strand DNA and low complement. She had a history of the abdominal pain a few days before admission, and the pain was preumbilical and postprandial. And on her examination, there was no any sign of the severe tenderness, just mild tenderness and deep palpation of the abdomen. And on the admission, the patient had a high acute phase reaction and normal amylase and lipase. And so according to this problem list, I have a question first from the Dr. Shahnawaz, that what's your differential diagnosis and what's your diagnostic approach for this patient?
Yeah, thank you, Dr. Faizi. Interesting case. So this is like a 42-year-old lady with known lupus presenting with kind of acute abdominal pain. In approaching this patient, I try to personally classify my differential diagnosis in kind of 2 or 3 different categories. One, conditions related to the lupus. One, conditions related to the side effects of the medications of lupus. And then third, the common classical causes of abdominal pain. I try to categorize my differential diagnosis that way. In terms of lupus, obviously, in our literature, the most common cause of acute abdomen in patients with SLE is actually lupus enteritis or lupus mesenteric vasculitis, which are actually interchangeably used together. We can talk about it a little bit later, why they're used 2 different terms, in my opinion. So that would be my first differential diagnosis. The other thing I would think about, again, lupus related, is thromboembolic events causing mesenteric ischemia, especially if patient had anti-phospholipid antibody syndrome, which I saw that I think briefly that there was negative a couple of months ago, but that would be something I would think about. And then obviously we have lupus pancreatitis, but lipase and amylase were normal, so less likely in the differential diagnosis. We can have basically what we call it intestinal pseudo-obstruction in patient with lupus, but again, this patient has only abdominal pain, doesn't have a nausea, vomiting, I think, in this presentation, so again, less likely. And then thinking about the side effects of the medication, obviously, lupus patient being on chronic steroids and NSAIDs, we always think about peptic ulcer disease or complications of peptic ulcer disease like perforation. And of course, we think about infectious causes like infectious gastroenteritis, which could be sometimes with opportunistic infections like CMV or salmonella, actually, and gastroenteritis in lupus patients, which are immunosuppressed. We have a calculous cholecystitis in lupus patients, but again, this patient is post-cholecystectomy, so unlikely, it's not possible. And then obviously also like CMV colitis, as I said, or CMV enteritis. And then common causes of abdominal pain, no matter what, in a childbearing lady, I always think about something like ectopic pregnancy. We think about pyelonephritis. I saw that, I think the urine analysis was negative, so unlikely. Appendicitis or diverticulitis. So these are the things that would be my differential diagnosis generally.
Yeah, thank you. And what's your next step for diagnosis of the patient?
Yeah, so based on my differential diagnosis, I didn't see any pregnancy test for this lady. I would test for that. That's number one thing I would do. In terms of blood tests, I would order a lactic acid level just for the mesenteric ischemia, although it's non-specific, it doesn't rule out or confirm anything, but it's good information to have. And then the most important thing I would do next would be a CT abdomen with angiography with IV contrast without PO contrast. That would be the next thing that I would order for this patient.
Why do you want IV angiography for detection of the vasculitis?
Well, so that's a good question. If we're thinking about lupus vasculitis, that's usually small vessel, so that wouldn't be usually seen in the CT angiography. I would want the contrast to rule out other potential causes, which is kind of, as I said, if there is any thromboembolic events, like if there is different than lupus enteritis, if there is any mesenteric ischemia, or if there is any basically, large vessel involvement, but that's not part of the lupus mesenteric vasculitis usually.
Mm-hmm. Thank you, Dr. Shahnawaz. Dr. Khosrowshahi, what do you think about the differential diagnosis of acute abdominal pain in patients with lupus with history of the vasculitis at the disease onset? And what's your diagnostic plan for this?
I completely agree with Dr. Shahnawaz. He covered everything, very comprehensive list. Again, practically, when lupus patients come as any other patient who comes with abdominal pain, you have to rule out the most common causes. And yes, vasculitis is definitely one of the problematic causes of abdominal pain or manifestations, GI manifestations of the lupus patients, but it's very rare. So more commonly, we see a lot of our lupus patients who have abdominal pain related to their chronic steroid, even azathioprine. Her dose was pretty low, or other medications. So those are definitely rule outs. But if cases presented in CPC, I agree with the ischemic mesenteritis or lupus vasculitis being on top of the list for me as well. Definitely, that's something that can be in patients with history of vasculitis or can be completely unrelated. So if you can't find common reasons being the cause of abdominal pain, I agree with the approach of getting an imaging to make sure that it's not the vasculitis at this point.
Thank you, Dr. Khosrowshahi.
Here you can see upright chest X-ray and abdominal X-ray. Dr. Rodmer, could you report the X-rays for us?
Hello, everybody. Thank you for having me. It's very nice discussion and differential diagnosis provided by Dr. Shahnawaz and Dr. Khosrowshahi. And I think everything starts with imaging. And this is a very good approach for these cases to have an upright chest X-ray to detect pneumoperitoneum, and in this case, this was performed, and I can't see any pneumoperitoneum in upright chest X-ray, and the pattern of the bowel gas in abdominal X-ray is somehow non-specific, but maybe some small bowel loops are a little bit dilated on the right and the left side of the abdominal cavity, but there is no significant pattern of obstruction, maybe some air fluid levels in some distal ileal loops here. This is the upright abdominal X-ray, but we can't see any pneumoperitoneum in this case. So For the next step, it depends on the your clinical suspicion. If the possibility of pneumoperitoneum or perforation or microperforation is high, in your case, we can go for the next step, which is CT scan. As Dr. Shahnawazi very well stated, we should perform a CT scan with and without IV contrast, without oral contrast, and this would be optimal choice for us. Thank you.
Thank you, Dr. Radmat. You mean that we need just abdominal CT with IV contrast, without IV,
Sure.
without IV, without oral contrast. Okay.
Sure. Yeah, sure. I will discuss about it later on. Yes, thank you.
Thank you very much.
So, okay.
Here you can see different cuts of CT which was done with IV and oral contrast. Dr.
So
Radmat,
thank you. If you let me, I can show you the whole CT images of the case by DICOM format. If you stop sharing, I can share my screen and
yes, go on, please.
thank you. So yes, here's the CT scan of the case, and this is with the order was only with IV contrast at that time, without oral contrast, and you see at the upper levels we have no distension of the stomach, and the liver seems good. Mild dilatation of the small bowel loops is seen here, and maybe at the lower levels we see some abnormal ileal loops here that show a little bit mural thickening with a circumferential pattern and a mild upstream dilatation. We can see focal fluid collection adjacent to this abnormal loop. The pattern of enhancement is a little bit lower than the other bowel loops, which means we may have mural edema or signs of hypoxic condition in this case, but the rest of the bowel loops seem to be normal. If we come down here at the lower level, medial to the cecum, we can see another loculated fluid here in the mesentery. So in these cases, the most important point is finding look for pneumoperitoneum, and if we go to the left side of the abdomen at the upper levels, we can see here maybe, yeah, a small amount of pneumoperitoneum as only 2 small gas bubbles in extraluminal locations in here, which means we have pneumoperitoneum, but it's away from the main source of pathology at the ileal loop that was mid or distal ileum. So maybe we have a microperforation in this case. Okay, so I stop sharing, and Dr. Suruddin, please.
Thank you.
Thank you, Dr. Rodman. I have a question. If we have a problem with renal function and we couldn't use IV contrast for CT, is CT scan without contrast helpful for diagnosis of vasculitis or not?
Definitely, it would help because we can find pneumoperitoneum in a non-enhanced CT scan very well, and other signs of transmural necrosis like intestinal rheumatosis or paper thin appearance or bowel perforation can be easily seen in non-enhanced CT scan. Contrast enhanced CT can help us to detect the pattern of inflammation or early ischemic changes. But when we are dealing with a patient with later stage of ischemia, like a patient who has transmural necrosis, and non-enhanced CT is enough for us. You know, for prescription or administration of IV contrast, the GFR level is important for us, not serum creatinine level. And if it is less than 30, the contrast injection or iodine-based contrast injection is absolutely contraindicated.
Thank you very much.
Abdominal CT report by radiologists said mild mucosal thickening and mucosal hyperintensive and distal jejunal loop is about 20 centimeter with adjacent fat strangling and mesenteric fluid in favor of acute enteritis. No phlegmon or collection formation is detected. Minimal fluid is present at lower abdominal cavity.
Dr. Ahmad, you can see that there is no any report of the pneumoperitoneal in this report. What's your idea about this? Is it common that don't report the pneumoperitoneal if it is small or not?
Yeah, in such cases, I think it's inevitable. When we have a very small amount of pneumoperitoneum, like this case, very far away from the main location of pathology, it may occur. I'm not going to justify the work of the radiologist colleague in this case, but in my opinion, this small amount of pneumoperitoneum could be missed even by an experienced abdominal radiologist. On the other hand, when we look at the patient's signs and symptoms, in such cases who are immunocompromised, like this case, the signs of peritonitis might be underestimated, and this could be another cause of missing this important finding in this case. And needless to say that most of us are working in centers that are high volume center, and with the high workflow of the radiologists, this may cause a negative impact on the practice, and this might be missed. Yeah.
Yeah, thank you very much, Dr. Rodman. And Dr. Khosrowshahi, we noticed that the patient has a diagnosis of lupus mesenteric vasculitis. What's your idea about the treatment of the patient? What do you suggest?
Sure, these are very challenging cases, and it requires really multidisciplinary approach. So definitely the vasculitis is an inflammatory cause related to the lupus that initiated the process and needs to be treated. But at the same time, I would like my GI colleagues and surgical colleagues to be on board, because we are dealing with an ischemic bowel that in an immunosuppressed patient that we're going to be putting on more immunosuppression can cause complications. In terms of lupus treatment, we usually treat these patients with high dose of a steroid, and definitely as soon as we make sure that there is no bacteremia, and GI is also making sure that there is no risk of perforation and significant infection, we have to even escalate the immunosuppression further. Here we consider rituximab or cytoxan for treatment of patients who have cyclophosphamide for patients who have vasculitis, ischemic, causing ischemia.
Yeah, that means it's better to use immunosuppressive first with high dose of steroid and then cyclophosphamide or rituximab, and coverage of the bacterial broad spectrum antibiotic. Okay.
For sure, yes. I would start this patient on pulse dose steroid with like 1 gram of solumet or methylprednisolone, and definitely not pull the trigger to put the IV cyclophosphamide until the whole team is on board, and gastroenterologist Dr. Shahnawaz and the rest of the team have seen the patient, and then with their agreement put patients on further immunosuppression.
How many pulse of the methylprednisolone do you prescribe for hair?
So usually we do 3 days of 1 gram of methylprednisolone. That depends. Definitely, there are not really studies or data supporting how many days of high dose of steroid these patients require. But based on other vasculitides, we think that 3 days should be enough, and there is no point of giving higher dose. I mean, definitely high dose of steroid is going to cause further complications, and this patient probably will require surgical intervention. So I think at this point, my plan would be giving 3 days and moving on to other immunosuppressive treatments.
Yeah, thank you, Dr. Khosrowshahi. Dr. Shahnawaz, what do you think about the treatment of this patient?
Yeah, so I mean, one thing I want to point out, I think Dr. Rodmer also mentioned, is that we need to be very cautious in these patients who are chronically immunosuppressed. Their symptoms may not show the gravity of the situation. Symptoms of severe necrosis or severe or perforation could be masked, could be clouded by the chronic anti-immunosuppressive therapy. So always have to have a high suspicion for catastrophic situation like a pending perforation or basically severe necrosis or gangrene of the bowel. So I would, if there is a question about free air, if there's a question about fluid collection, yes or no, I would have my surgical colleagues on board earlier than later, because I think some studies has shown that if you need to do laparotomy, if you act within the first 2 days, your prognosis would be way better than you'd wait and do this later. So I would, in my service, I would see the patient, but I would ask my surgical colleagues also to review the case with me, be on board. But assuming that we rule out perforation, I think that's reasonable to go ahead and start high-dose steroids. From GI standpoint, other than high-dose steroids, we would just give bowel rest and IV fluid resuscitation. Some people may give PPI, but there is not really that much evidence to support that. So that would be from the GI standpoint, basically. If the patient start on the, you were talking about how many days of pulse steroids. If the patient start pulse steroids and within 48 hours, there is no improvement in the clinical picture, then I would definitely repeat the CT scan, even if the first one did not show any necrosis or any basically perforation. So I have a low threshold to repeat the CT scan.
Thank you, Dr. Shannon. And I have a question. How long do you need bowel rest for lupus vasculitis, mesenteric vasculitis?
It goes kind of more with the patient's symptoms. You can start basically liquid diet and then advance it when patient says that the pain is better, and then when the patient can tolerate the liquid and doesn't have nausea, vomiting. I would say at least for the first 2 or 3 days, I would give, at least for 48 hours, I would give complete bowel rest until the steroids kick in. But then after that, it's based on the patient's symptoms.
Thank you. Thank you very much.
Professor Faizi, we have a question here in the chat box. It said that I understand that the patient's abdominal exam has been almost normal aside from mild tenderness on deep palpation and somewhat decreased bowel sounds, which he wondered how you define it. And it is asked from Dr. Rodmard, why were you that concerned for free air and perforation? Dr. Rodmard, can you help us here?
Yeah, we saw the pneumoperitoneum, so this would be important for us in this case. But sometimes we have pneumoperitoneum in completely sterile condition, like bubbly pneumatosis that are completely benign, that may have been ruptured and goes into the peritoneal cavity. But in this scenario, I think this is very important because for us, because it means we have a microperforation. Although the location of the site was far away from the side of the abnormal bowel loops, and we saw the fluid collections adjacent to the bowel loop without any gas bubble within the collection, it means this is an alert for us, and we should go for the next step. Definitely, we should ask the surgeon to come, and if they want to have a conservative management, we should have another second CT scan at least 24 or 48 hours after this first CT scan to follow this abnormal finding.
Thank you. The first question was about the this appropriate finding on physical exam of this patient. Dr. Shanna, could you tell us?
Yeah,
more?
that's a good question. I mean, we all learned that in a mesenteric ischemia, at least I can say that there is not a good relation between the physical exams and basic patient symptoms. So that's one part of it. And the second part, as we said, is that people who are immunosuppressed, people who are chronically on steroids, the physical exam could be very deceiving. So It's important to do that and pay attention to that, but it doesn't rule out something more basically serious if the physical exam is remarkable.
Thank you very much.
Can I add something?
Yeah.
It was mentioned, Dr. Shahna was mentioned about the coagulopathy in lupus patients, and I know there was mention of the antiphospholipid antibodies were negative in the past, but that's also something that I would definitely reconsider now that we are dealing with a patient who seems like, yes, serologically she was active on previous visits, but seems like clinically was doing well, and all of a sudden is coming without any other systemic activity of her lupus, like usually the malar rash arthritis is not active, and all of a sudden with mesenteric vasculitis, I would definitely look further into antiphospholipid antibodies, or in some cases, we would start these patients on anticoagulation just to make sure, because we know with any type of vasculitis, risk of further thrombosis and coagulopathy is high because of the amount of inflammation in the blood vessels. So that is another consideration that needs to be considered, and probably start the patient on IV heparin. That is not something that I would say generally I do for every patient with abdominal vasculitis, lupus vasculitis, but I will consider it and keep it in mind.
Yeah, thank you, Dr. Khosrowshahi. And as you mentioned, the patient has no other manifestation of the disease activity. But you know that the patient had, at the beginning of the disease, has some mucocutaneous manifestation, arthritis, and the main manifestation was digital vasculitis. And the drugs that the patient are taking, such as low-dose prednisolone, azathioprine, and hydroxychloroquine, can control the mucocutaneous and the musculoskeletal manifestation, but these drugs cannot control the vasculitis. And so the lackage or absence of the other manifestation in this patient cannot rule out the disease activity, especially in this patient with this presentation at the disease onset. And I think the presence of the anti-double strand DNA, low complement, and high acute phase reactant is very important to pay attention to diagnosis of relapse of the vasculitis for this patient.
Completely agree.
Yeah, thank you.
Okay, we have two other questions here. May I read them? First, it's the question from Dr. Shahnawaz. It says that after 3 pulses of methylprednisolone, patient had normal vital signs, normal examination, and normal abdominal X-ray. So do we here still have to do the abdominal CT scan again?
No, I would, no, that's reassuring, but also if the patient's abdominal pain, which was the presenting symptoms, has improved, other than exam, if the patient abdominal pain has improved and with everything else normal, I do not push for a repeat CT scan. If patient's abdominal pain has not removed after 48 hours, I would recommend repeat CT scan.
Thank you very much. And also, we have a question from Dr. Rodmard. It says that although you showed us a gas bubble, is it possible patient did not have microperforation despite receiving corticosteroids? The abdominal X-ray was normal after methylprednisolone.
Yes, when everything is normal, I mean, in clinical condition of the patient, we are not going to just focus on the imaging findings. We want to treat the patient, not the imaging abnormalities. But in this case, based on my personal experience, patients with intestinal vasculitis, we have a very rapid progress of signs and symptoms over time. And most of the time, we are running behind the time, and we should manage the patient and should be proactive in such cases. So maybe a normal abdominal X-ray after this CT scan can help us to be sure about the patient's better condition, but this is not enough, and we should not leave the patient, and we need to follow him up, her up.
So just add something to what you mentioned, and second, what you said, because the patient is on pulse dose of a steroid, the symptoms will be masked further. So we are not going to be catching the peritonitis symptoms as much. So that's why probably we should be a little more than our usual, non-lupus, non-immunosuppressed patients in terms of like not trusting just the physical exam and making sure that we are not dealing with any perforation. This patient will require further immunosuppression. So we have to escalate and we have to put them on maintenance therapy because we're dealing with vasculitis. We have to put them on either IV cyclophosphamide or IV rituximab. So it's going to be very important to make sure there is no perforation. So that would be something that I would bring back to the GI and surgical team and make sure that, yes, the patient is doing abdominal rest. So most of the pain was postprandial due to ischemia. So now that patient has not been eating, may not have abdominal pain, and you are not having tenderness on your exam because they are on pulse dose of steroids, which is not causing much peritonitis symptoms. But is it safe to put them on cyclophosphamide? So that would be my next question to next reason to probably repeat the imaging.
Yeah, thank you, Dr. Khosrowshahi. I agree completely with you that in lupus patient with vasculitis, we have, especially abdominal vasculitis, we have no other choice just to give immunosuppressive high-dose steroid and then cyclophosphamide or rituximab for him to prevent the morbidity and mortality of the patient. Thank you very much.
Non-surgical therapy was recommended. She was NPO. She received intravenous fluid therapy and also received methylprednisolone as a pulse 1 gram for 3 days, and then continue with dexamethasone 4 milligrams 3 times a day. Her serologic result and admission shows anti-double-stranded DNA 200, C393, C418, anti-Rho10, anti-cardiolipin, anti-beta-GP1, all were normal. Lupus anticoagulant was 36. Her abdominal pain relatively improved with high dose of steroid therapy. On 4 days of admission, she complained of worsening of epigastric and preumbilical pain. She was MPO. She didn't have nausea, vomiting, diarrhea, and bleeding. On her abdominal physical examination, the abdomen was soft, mild epigastric tenderness in deep palpation, no guarding or rebound tenderness.
Thank you. Dr. Shahnawaz, what do you think about this manifestation? Do you suggest any more evaluations such as endoscopy or more CT or abdominal X-ray?
So my understanding was that the symptoms improved, correct? After that, and exam was benign. As we mentioned, symptoms could be misleading sometimes. So if there was any concern, as Arezou said at the beginning, that it could have been something and now we want to escalate the treatment or add extra immunosuppression, I'm not opposing repeating CT scan. That's one thing. In terms of endoscopy, you mentioned, generally for lupus enteritis, the role of endoscopy is very low and it's usually not revealing. One reason is because they usually have involvement of the jejunum and ileum, and that's something which is not easily be accessed by the upper endoscopy. The second thing is that there is a kind of high risk of perforation to do endoscopy or colonoscopy in these people. If we decide to do that, it's usually to rule out other conditions. It's to rule out peptic ulcer disease or rule out basically necrosis of the colon or basically that. And then it has to be done by a very experienced endoscopist, gastroenterologist with minimal air insufflation. And basically, but then the other thing is that endoscopy, basically the biopsy that we get a lot of times, most of the times, I'm sure Dr. Kosari can comment on that, is not diagnostic because it's not deep enough to go and see the submucosal area and vasculitis, sample that area. So generally, I would not recommend endoscopy. And in my experience, when it has been done, it hasn't been very helpful unless there is concern about other conditions.
Yeah, thank you. Dr. Khosrowshahi, do you have any comment?
No, I completely agree.
Yeah, thank you.
On surgery consultation, 4 stays of admission, their abdominal examination shows that abdomen was soft with mild epigastric tenderness in deep palpation, no guarding, no rebound tenderness. They recommended upright chest radiograph. Here you can see the upright chest radiograph on 4 stays of admission. Dr. Rodmark, could you report the X-ray for us?
It seems we don't have pneumoperitoneum yet in this X-ray, and this is a good sign for us. It means we didn't have any progression in the patient status. Maybe sometimes these small microperforations might be sealed off, but we should reconsider the sensitivity of the chest X-ray or upright chest X-ray for detection of pneumoperitoneum, which is not too high for us. So it would depend on the patient's clinical status that was stable at that time. Maybe we in such cases, if we go back and review the first CT scan, we can find some other relevant findings that can lead us to go for the next step, which can be another CT scan. With the sensitivity of the upright chest X-ray, based on the literature that we have, is very wide, from 30% to 78%. But based on my personal experience, I wonder the sensitivity of the chest X-ray, upright chest X-ray for detection of pneumoperitoneum would be more than 50 or 60% in the real practice. So in such cases, I would recommend CT scan to confirm and to reassess the previous pneumoperitoneum that was detected in the first CT scan.
Thank you very much.
On GI consultation, 4 stays of admission, they recommended upper endoscopy that showed erosive gastritis. Colonoscopy was not completed due to poor preparation. H. pylori eradication was recommended. PPI and antibiotic for eradication of H. pylori were prescribed for her. She had relatively improvement on her abdominal pain. On 10 stays of admission, she complained of worsening of abdominal pain. It was generalized and constant. On her physical examination, she looks ill. Temperature was 37 degrees, blood pressure 120 over 80, pulse rate was 120 beats per minute, respiratory rate 24 breaths per minute. There was generalized abdominal tenderness, no guarding or rebound. Her laboratory result on 10 stays of admission showed WBC 24,610, hemoglobin 12, platelet count 453,000, creatinine 0.79. Her VBG was pH 7.30, PCO2 34.7, bicarbonate 17. And the upright chest radiograph 10 stays after admission. Dr. Rodmark, could you report?
We have an overt pneumoperitoneum in both sides, and also we see a dilated loop of maybe colon in the left side. So interestingly, the patient did not have guarding or rebound tenderness, as I understood from your clinical history, and this is an important clue for us to revise all these, all we had learned from the physical examinations in these patients who are immunocompromised.
Thank you.
She underwent emergent abdominal surgery. Description of surgery said from 60 centimeter of trace ligament, it was through gangrene with lengths of 150 centimeter. Then 10 to 15 centimeter with good color, again gangrene 50 centimeter. Then up to 10 centimeter was good. Again, the gangrene had been extended to middle of transverse colon. SMA artery pulse was detected, but with no peripheral pulses. Here are the sample of pathology of GI. Unfortunately, we couldn't have Dr. Kosari with us today, so I'm gonna describe some of them. Here is the low power field that show colon. Here we can see submucosal microthrombi. Again, in this sample, we have submucosal microthrombi, mucosal infarction in colon, mucosal infarction in small intestine, transmural infarction in colon. GI pathology report said extensive mucosal infarction of small intestine, fibrinolymphocyte with exudate on serosal surface. Some capillary size vascular structures show microthrombus formation. No site of perforation is identified in thorough gross examination. Resected colon shows focal transmural infarction. Proximal resected margin shows focal mucosal infarction. Distal resected margin is wild. Vermiform appendix shows active appendicitis and periappendicitis.
Okay, thank you. We noticed that we have a patient with lupus mesenteric vasculitis that received high dose of steroid, and despite the high dose of the steroid, she progressed to the her manifestation with worsening of the abdominal pain that at the end underwent to the surgery, emergent surgery. And according to the gross pathology that reported by the surgeon, we have a multifocal infarction with some intervening normal bowel that and with some manifestation in pathology such as mixture thrombi and vasculitis. Dr. Admar, could you compare the gross pathology with the finding of the abdominal CT at the beginning of the admission? Is there any progression to the GI involvement and despite the high dose of steroid?
Definitely we had. I think the pathology at the first CT scan was limited to the mid to distal iliac loops. I can say that colon was definitely normal in that time. So in spite of this treatment, we had escalation of the findings, and this means we have multifocal involvement, not in a specific territory of a vessel, which means we have a small vessel involvement, colon and small bowel. And I think, yeah, sure, we can say that we had a progression of the disease in spite of this treatment, and maybe we should think about the change in the treatment or increase in the dosage of the medicines. Yeah.
Yeah, thank you, Dr. Adnan. Dr. Shahnawaz and then Dr. Khosrowshahi, for prevention of the progression of the GI involvement in this patient, which strategy do you suggest? More dose of the pulse of steroid or initiation of the cyclophosphamide earlier or earlier surgery for this patient?
Yeah, I kind of think that the steroid high dose was started correctly, and I don't, from my experience, usually cyclophosphamide is added to the steroid, not in the first time, as was mentioned before. So yeah, it's kind of unfortunate that patient was doing better, and then suddenly it sounds like had a massive gangrene and necrosis of the large part of small bowel and colon, which actually with that much resection, patient is obviously in a high risk of developing a short bowel syndrome in the future. That's something that should have been prevented. But in terms of what strategy, as we said, we have to have a very low threshold to repeat the scan. And also at some point, I have seen that the surgeons may consider laparoscopy to evaluate the liveliness of the bowel before it's too late. That's something I have seen that they do that. Basically at a very early stage doing the laparoscopy, evaluating the bowel before getting too late and the patient need laparotomy and resection. As we discussed, obviously EGD endoscopy did not show because it cannot access that far into the bowel, so it didn't see any bowel necrosis or pending ischemia. So yeah, I would just I don't know if maybe surgeons need to be kind of more on board and consider laparoscopy at some point in the early course of the disease.
Thank you, Dr. Shahnawaz. We have the worsening of the vasculitis in this patient. Do you think that the laparoscopy can prevent pathogenesis of the vasculitis in this patient?
No, it would not, but it would, I wonder if at some early stage, basically would see the early signs of necrosis or ischemia of the bowel, diagnostic laparoscopy.
It's not tools to prevent the progression of the disease.
No.
Yeah.
No, I agree 100%, yes.
Yeah. Dr. Khosrow, thank you, Dr. Shahnawaz. Dr. Khosrow-Shahi, what's your idea?
Yeah, I completely agree. I think the pulse dose steroid was the initial approach. So I don't remember that if this patient was started on anything else, and this is 10 days out. So I would say most likely on this third day of the pulse dose steroid, initiating cyclophosphamide or rituximab would probably help. I'm not saying it for sure because we know cyclophosphamide and rituximab, both of them take time. So they take, like rituximab, definitely at least 2 weeks, and cyclophosphamide a week to completely work. But this is the experience that we have from lupus vasculitis and even ANCA-associated vasculitis, that the steroid alone is not gonna calm down the vascular inflammation. So that needed to be on board. One of the other things that I was thinking back is probably initiation of antibiotic. That's not gonna prevent vasculitis and the progression of the ischemia, but what we are seeing right now is probably the patient is with necrosis, sepsis, and everything else, and with high dose of a steroid. That was something that I would have added as a general empiric treatment.
Yeah.
Also.
Thank you, Dr. Khosrow. Do you have any experience with more than 3 doses of the pulse of methylprednisolone? You know, some field of, such as neurologists, they use around 7 pulse of the steroid for CNS vasculitis. Do you have any experience? You know, we use it for some manifestation of the vasculitis, such as CNS vasculitis and SLE, and there's some recommendation that it's better to use pulse of steroid until the removal of the manifestation.
I mean, these suggestions are mostly not based on the clinical trials or any evidence-based recommendations, but yes, you talk to 10 rheumatologists, you will get different opinions of 3 days of pulse steroid, 5 days, 7 days. Depending on the patient, you can make a decision. Depending on how easy or fast you can start cyclophosphamide or rituximab in these cases, you can even make a decision to continue until you can get the patient consented and started on cyclophosphamide. So I think based on what I heard, the patient's symptoms improved somewhat on the 3rd day or so, and then seems like it got worse. So that could have been a possibility, that when the patient's symptoms got worse, maybe she could have gotten a steroid, but I think that would have been too late because the symptoms were coming after the worsening of ischemia.
Thank you very much.
Okay, Dr. Faizi, we have 2 questions here.
Can you ask your question at the last slide, end of the?
Okay.
Yeah.
Antibiotic therapy started for her because of positive Klebsiella and E. coli in abdominal fluid culture. She received heparin infusion because of mesenteric ischemia, and also antiplatelet therapy because of troponin rising and the non-ST elevation MI, which was happened after surgery. She received IVIG 125 grams because of disease activity while she had an infection. TPN therapy was started because of extensive intestinal resection. After having negative blood culture, urine culture, and bone culture, patient received IV cyclophosphamide 1 gram 10 days after surgery. She was discharged 15 days after surgery in good condition with prednisolone 60 milligram per day and hydroxychloroquine 400 milligram per day. Dr. Rodman, would you like to share your slides with us?
It's my turn, yeah, sure.
Yes. I'm going to stop my slides. Go on, please.
May I ask the questions now, Dr. Faizi, before the slides?
You can ask, yeah. You can ask.
So one question was that is it possible that after the colonoscopy the patient got worsened? And the second one is a question from myself, from Dr. Shahnawaz. I remember that in patients with IBD who did not respond to the pulse of corticosteroids, we might prescribe them with cyclosporine. And we said that it is an immunosuppressive that has somewhat faster response in patients. Is it possible that in enteric vasculitis we could get the help of cyclosporine or not? Thank you.
Yeah, thank you. So the first question, that's a good question, actually, that the colonoscopy worsened the situation. I don't think that the colonoscopy is the cause of that massive gangrene and necrosis, but there are reports of worsening of the mesenteric ischemia after colonoscopy. And that's the reason that I personally would try to avoid endoscopic procedures in this patient, with one part maybe the massive prep and dehydration from that, and also the second one from the putting air in the gut, in the colon. It can worsen the ischemic colitis, or it can worsen the mesenteric ischemia in some reports. I don't think that's the cause of this basically severe necrosis throughout the small bowel and big part of colon. For the second question, you're right, we sometimes give cyclosporine to IBD patients who don't respond. To be honest, now we are moving more to giving infliximab to these patients in the hospital rather than cyclosporine, because of the, first of all, it needs a lot of experience to be able to manage cyclosporine and the kidney toxicity and other stuff. I'm not aware of cyclosporine given for vasculitis or mesenteric vasculitis. Maybe Arezou has better experience. I have not seen cyclosporine given to the mesenteric vasculitis patients.
The same. I have not tried it, and I don't think there is much evidence showing cyclosporine would work for this kind of like vasculitis.
Yeah, Dr. Bahaban, you know that lupus mesenteric vasculitis is one of the most devastating manifestation of the disease, and that led to the mortality in around 50% of the patient. Mm-hmm. So in this disease, we have to use a strong immunosuppressive, that the cyclophosphamide is the best immunosuppressive for this patient. Dr. Rodman, please.
Thank you. I have prepared very few slides to describe the imaging findings of intestinal vasculitis, starting with this case from my institution. It's a 29-year-old female, was a known case of SLE, presenting with fever, malaise, generalized abdominal pain, dyspnea, and elevated ESR. On CT scan, you see the diffuse mural thickening in the iliac loops here with somehow non-specific pattern with mesenteric engorgement. Based on this imaging finding and this feature per se, we cannot have very specific diagnosis. This could be either due to lupus enteritis, but enteric infections, or even other inflammatory conditions or drug reactions may cause such appearance. If we go to the higher levels, in this case, we see signs of lupus nephritis in both kidneys, as these hypodensities in the cortex of these kidneys. And at the higher levels, we can also see signs of infarct in the spleen. And again, at the limited cuts of thorax, we can see precardial thickening and mild effusions, suggesting presence of serositis in this case. And also at the long window, we see features of low-grade lupus pneumonitis in this case. So the constellation of all these imaging features together can help the radiologists to think about intestinal vasculitis, and we need all these together. And Professor Faizi asked me to describe this interesting sign of thumb printing sign for the detection of bowel ischemia. But as you see here, the long list of differential diagnoses can cause this imaging appearance in the bowel loop, including IBD infections, bowel ischemia, hemorrhage, or even infiltrative conditions. The sign is very similar to the impression of the thumb over the surface, something like this, and we can see it in the even in abdominal X-rays, like this case of colitis. Here, this is the thumb printing sign, but it has been described even in a CT scan, like this case of lupus colitis. We can see this. It means we have edema and thickening of the colonic hostra, and this may cause this thickening and thumb printing sign. But I would like to draw your attention to the process of the acute mesenteric ischemia due to any etiologic factor. When we dealing with a patient with acute bowel ischemia, we should think that this is a time-sensitive dynamic process, starting from a vascular compromise or hyperperfusion, goes to the acute mesenteric ischemia. If the etiologic factor persists, it goes to the bowel necrosis, and eventually we will have organ failure and death. But please keep that in mind. If you look at this diagram, we see the mortality rate increases up to 60%, 12 hours after development of the ischemia, which means we have a very, very short golden time of decision in these cases for the management. Regarding the imaging protocol, the cornerstone of diagnosis in these cases is CT scan, and the sensitivity and specificity of this modality is more than 90%. The technique or protocol was discussed in the presentation. We need a pre-contrast CT, an arterial phase CT with MPR by reconstruction of the vessels, likely angiography, and the portal phase of contrast injection. But please keep that in mind, that we are not allowed to use oral contrast, especially positive oral contrast, because we may miss the enhancement of the bowel loop. And also, please consider this, that when we ask the patient to ingest oral contrast, it takes something around 2 hours that the patient can ingest all these oral contrast. And if you remind the golden time of decision, we easily will lose the 2 hours of this time of management in these cases. But we as the radiologists have some clues to think about intestinal vasculitis. If the bowel ischemia occurs in a patient who's young, we should think about this, and especially when the ischemia is not specific to a territory of the mesenteric vessels, not specific to SMA territory or IMA territory. Like this case, we had necrosis in different territories. When the neural involvement does not have any predilection to one side of the mesenteric, to one side of the bowel wall, we should think about intestinal vasculitis. As you know, Crohn's disease has a predilection to involvement of the mesenteric side of the bowel loop. And also, a very useful clue for us is other extraintestinal findings, like the case that I showed you. Sometimes they are the only features that help us as a radiologist to put the diagnosis of intestinal vasculitis at the higher levels. And also, please keep that in mind that we have a considerable progress in extent of bowel involvement in these cases, and we are not allowed to waste the time, because any time wasting may cause a catastrophe in these cases. And one interesting and helpful feature for us is these cases usually has very rapid response to immunosuppressive therapy. But in order to make the correct diagnosis of intestinal vasculitis from the radiology side of view, the imaging features need to be linked with the relevant clinical and lab data in a two-way street. And for those who are interested to learn more about the imaging of the intestinal vasculitis, I would recommend this comprehensive educational review that we published in the Journal of Insights into Imaging from our institution, and they can read this interesting review. And this, the educational exhibit of this paper received the prestigious award of magna cum laude from the annual meeting of the European Society of Gastrointestinal and Abdominal Radiology in 2021. So I think as a radiologist, I can say that we need this data from your side. We need data from the clinician side about the lab data and all the clinical information, and then we will take them, and then we can give you more correct diagnosis. The radiologist does not have a magical stick to create a diagnosis for you, and we need this information from the clinician side. That's it. Thank you for your attention.
Thank you, Dr. Radna, for your nice presentation.
So let me stop share the screen, I think. Yeah.
Yeah, if there is any question or comment. Dr. Barwan, no question?
All of the questions here in the chat box have been covered. There is no question. Yeah.
Thank you very much. Yeah, I'm going to tell some information about this patient and about the lupus mesenteric vasculitis as a take-home message. You know, as Dr. Khosrowshahi mentioned, the prevalence of the lupus mesenteric vasculitis in SLE patient is really uncommon. It's usually less than 1%. But when we have a SLE patient with acute abdomen, the prevalence increased even more than 60%, especially a patient who has a disease activity, especially SLE more than 8 can be associated with lupus vasculitis, mesenteric vasculitis in a patient with abdominal pain, and most of them have a high acute phase reactant as well. Lupus mesenteric vasculitis is the main cause of acute abdominal pain in patient with SLE, and it is one of the most devastating complications of the lupus, and with mortality rate of around 50%. In this slide, you can see that the pathogens of the lupus vasculitis is related to the immune complex deposition that led to the complement activation and then extravasation and edema and veno-occlusive plaque and thrombosis. And there are some proposed trigger factors such as infection, drugs, and chemical and other factors that they can activate inflammation, and they can lead to the vascular changes such as leukocytoclastic formation and secondary to immune complex deposition, occlusive vasculopathy, thrombus formation, intestinal ischemia or infarction, or both, and hemorrhage and perforation. And you can see that depending on the site of the inflammation, we have different manifestation. We have an inflammation in mucosa, we have ulceration, hemorrhage, and diarrhea. In submucosal, we have a submucosal edema, a pseudotumor, and in muscular part of the bowel, we have pseudo-obstruction, dilatation, and fluid accumulation, and serosa, we have serositis ascites. About the clinical manifestation of the patient with lupus mesenteric vasculitis, there's a a variety of range of the manifestation from mild to very severe, and most of them have crampy or constant abdominal pain. It's usually postprandial pain or fullness. Sometimes it has hematemesis, melena, fever, vomiting, or diarrhea, and as all of the invited speaker mentioned, there's no correlation between the sign and symptoms of the patient in their abdominal examination. And this study was very interesting, that showed that most of their patients with lupus mesenteric vasculitis were admitted to the inappropriate department because of the variety of the manifestation, and most of them initially misdiagnosed, and they showed that around 26% of lupus mesenteric vasculitis was the first manifestation of the lupus in this study. And as Dr. Radman showed, we have to use tools to make a diagnosis as early as possible. And see the findings that are diagnostic for lupus mesenteric vasculitis include bowel wall thickening, target sign dilatation of intestinal segment, engorgement of mesenteric vessel, and increased attenuation of mesenteric fat. And sometimes may have no access to CT, that radiographic finding can be help us for diagnosis of inflammation of the bowel, such as pseudo-obstruction of the gastric outlet, duodenal stasis, effacement of the mucosal fold, and thumb printing, as Dr. Rodman mentioned. And this study shows that the CT score for SLGI involvement were positively correlated with patient time to tolerate PO intake more than 50% of ideal calorie. That means when we have a severe finding in CT, that means patient has worse outcome as well. As Dr. Shahnawaz mentioned, biopsy is not always necessary if the clinical scenario and the radiography findings are highly suggestive, and when biopsy are performed, results are usually inconsistent because of the superficial nature of the technique. And in one study, in one review of 150 cases of lupus enteritis, 34 patients underwent a biopsy, and only 9 of these patients had straightforward histologic vasculitis. In microscopy, we can see the swelling of the bowel and variable degree of the ulceration, perforation, and gangrene. And in microscopy, we can see fibrinoid necrosis, leukocytokilosis, microthrombi, and a diffuse inflammatory infiltration. For treatment of the lupus mesenteric vasculitis, they typically respond to high dose of corticosteroid that are generally given in IV formulation initially, and then until clinical improvement is noted, and then continue in oral form and taper over weeks to months. And immunosuppression such as cyclophosphamide can be added in refractory or recurrent case. This is a recommendation, but for patients with history of the vasculitis in other parts of the body, such as this patient, it's better to use it after the high dose of steroid. And additional measure, as Dr. Shahnawaz mentioned, bowel rest and IV fluid. This study shows the different management that used in different study for lupus mesenteric vasculitis. Most of them were case series or retrospective study, and as Dr. Khosrowshahi mentioned, we have no any RCT or strong recommendation for treatment of lupus mesenteric vasculitis, but all of them use methylprednisolone, and some of them most of them use cyclophosphamide as immunosuppressive therapy. And for response to therapy, relief of symptoms usually take less than a week, but sometimes symptoms may persist up to a few months, but not worsening of the symptom. And there are reports of the recurrence of the vasculitis in around 30% of the patients. and the presence of autoantibody against antiphospholipid and endothelial cells can increase the rate of the recurrence in these patients. And there are some report that previous steroid administration can mask the symptoms in some patients, and they may promote thinning of the bowel wall, which led to perforation. That I don't know about the pathogenesis of this side effect. And in this, when we have no rapid response to immunosuppressive therapy, the next appropriate approach is consider surgical intervention for possible bowel perforation or large area of ischemia. Thank you very much for your attention, and thank you all of the invited speaker. And if there's any comment or question from the invited speaker, I'm glad to hear.
Thank you so much for this nice presentation. I really appreciate all the discussion. Just mention that when we have these cases, lupus cases, young patients who usually come with this manifestation, I always tell my fellows that these are the worst prognosis. So we have to be very aware of that and watch this patients. As you mentioned, the symptoms are not very helpful. So the signs that we can get from any like vital signs, blood work, any imaging that can help us to understand the progression of the disease and be on top of that. Multidisciplinary approach, so rheumatologists cannot handle that by themselves, so definitely having GI and surgical team on board and alerting the the primary team. We have internal medicine teams taking care of these patients and saying that these patients have high mortality rate because we are dealing with an area that is very, very highly inflammatory and at the same time can cause perforation, sepsis, and because of the main treatment is immunosuppression. So these people have high mortality rate. Going to the case, we know the prognosis is going to be poor, but we do our best. And I have a low threshold to put these patients on cyclophosphamide or rituximab from the beginning. I know majority of the literature says refractory cases, but just imagine when you deal with the first one and we get rid of the inflammation with a steroid not ending up in perforation, you don't want to risk it for the second episode. So that's my strategy usually.
Thank you very much, Dr. Khosrowshahi. Dr. Shahnawaz, Dr. Rothman.
Yes, thank you very much for inviting me. That was a great discussion. I learned a lot. It was a very informative discussion. Again, that emphasized that we have to have a very low threshold for any sign or symptoms that patient may show during their presentation. Maybe as Dr. Khosrowshahi said, the first response, which is natural to steroids, should not make us to be very happy and proud of ourselves. We have to have always a very suspicious mind for this patient. One thing I was thinking actually, and I don't know, is that if this patient had maybe more frequent lactic acid every day, from this, like every other day or every day, maybe it would have shown some signs that it's going toward, despite the clinical improvement, if we had seen some acidosis or elevated lactic acid from day 2 to day 10, maybe that would have triggered more attention sooner than waiting for 10 days. That's one thing I could think of. But yeah, that was a great discussion. I really enjoyed it. And thank you very much for inviting me and having me here.
Thank you very much, Dr. Shahnawaz. Dr. Rothman.
Well, thank you again for inviting me. And I learned so much from this case. And I think from maybe the most important point from the radiologic side is we should have a specific attention to these patients who are immunocompromised. Maybe the radiologist in this case had a mistake for detection of this pneumoperitoneum, but in my opinion, this is inevitable, and we learn from our mistakes, and we have to put all these mistakes into our practice and improve our management skill. So I wonder if the radiologists who made the report had this enough and this comprehensive information about the patient. And we need this information again, and we need this clinical and lab data and this close interaction with the clinicians to have a better judgment for the management of the case and make a better diagnosis. Thank you.
Thank you, thank you, thank you all of you for discussing these cases, and I really enjoy for this discussion, and I hope to see you in the next CPC as well. Dr. Baharwan, do you have any?
Thank you very much. Thank you all for being here with us. And as always, I would like to ask you to fill the evaluation form for us. I have shared the link of the Google form with you in the chat forum. And if you fill it, it will help us improve our sessions. Thank you very much. Have a nice day.
Thank you,
Goodbye.
Dr. Khosrowshahi.
Thank you.
Dr. Shahnawaz. ممنون از تشریف فرماییتون.
متشکرم.
Thank you.
ممنون.
متشکرم.
متشکرم.
ممنون.
قربان.
خوشحال شدم. خداحافظ.
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 خداحافظ.